if I don't know the answer, I will call Dr. Bates and you will get your answer.
Right.
Because there's some situations where patients, like, nothing adds up, numbers are all wrong, nothing adds up clinically, you know, you can't put the piece, and I'll call Nathan and be like, look, I'm kind of confused. Like, the numbers don't add up, you know, this is what's going on, and I'll get my direction from him. You know, there's been a couple times, like, you guys call me out, I'll be like, all right, let me call Dr. Bates. So, you know, there's scenarios where I'm stumped, you know, so it is what it is.
Hey, earlier Craig mentioned painting the picture. He and I'm always picking Craig, right? So he and I went into a patient's room, and he said, look, he had me look at the chest tube output. He, instead of looking at things in a singular fashion, he had me look at a bigger picture, which included the overall chest tube output for my 12 hours, in addition to the cardiac output index, PA pressure, CVP, all that kind of fun stuff. So basically, although everything looked okay to me and my patient seemed safe and the platelets were fine and hemoglobin, the H&H were fine, in the safe range, 7.8 is what, as a matter of fact, exactly what it was, and 31.3 is what the H&H was. He said, your patient needs blood. And I'm like, huh? I said, the H&H is this, and he goes, no. Number one, look at your output, and he talked about the 3 components of blood, and how based on the amount of chest tube output, although it wasn't extreme, like it wasn't like over 100 an hour or 200 an hour, it wasn't like that, but it was excessive, and the color, he also had me look at the color. Those things I took in the back of my mind, they'll forever be etched in my mind, like, okay, instead of looking at H&H by itself, oh, they don't need anything, or just test tube output, oh, it's within the safe range, don't need blood, or just the PA pressure, the CVP. Instead of looking at those things singularly, by painting a better picture to, if I'm not calling him, I'll get what I need if I'm able to better paint a better picture for that surgeon who's not him or Bates, to get what the patient needs, so that way we're not behind the eight ball 12 hours later.
So the patient he's talking about had a credit like 24, it was 80, and SpO2 was 50. So previously it was in the 70s. So, like, instead of just keep giving him albumin and saline, give him blood, because if you give him a liter albumin or a liter of saline, you're gonna drop the credit 20. Yeah.
And what happened
and
was,
an 80-year-old is not.
Lou and I asked for blood, and when he asked for certain numbers, I gave him the numbers.
Who's on call?
Political.
And
but,
so,
you know, like I tell him, like, you gotta tell him, like, the SpO2 dropped by 20%. You know, it was 70, now it's 50.
He's not
He doesn't
all
care
that
about
impressed
SpO2.
with the SpO2.
Yeah, but he practices 1990s medicine. Okay, literally, he that's what he practices. Like, they didn't have, I don't think he understands that. But so you guys know, like, the appropriate therapy. You know, instead of just blasting them with saline or albumin and pushing their crit to 20, 21. You know, why don't you just give a few minutes of blood? That'll fix 90% of their problems. You see what I'm saying?
so my point of saying all that was to paint a picture so that you get what the patient needs, instead of just the albumin and the fluid. And so that's what I didn't do a good job of, and now I'll do a better job of it now that I have that in the back of my mind.
Anything else?
Randy has a question. How do you guys decide if you're putting 1 pleural or 2 pleurals in?
You mean on the hearts?
Mm-hmm.
So basically, I look at their pre-op chest X-ray, and if they're in heart failure, or if their EF is low, most of the time they'll always get 4 chest tubes. So if it's a straight forward 3-vessel cabbage, not in heart failure with a normal ejection fraction, no pleural effusions, they'll get 3 tubes. But if they're elderly and heart failure with a low EF, and they got bilateral effusions, we'll put 4 tubes. Okay?
Can you repeat the very first part? My video wasn't going.
How do I know put 4 chest tubes in?
No, the first part as far as the PA pressures, the importance of knowing them pre-op.
Yeah, well, here's a scenario I told Kevin. Like,
Yes.
You know, you got a bad AS patient like the guy in 10, right? So his PAD at the start of the case was 25. So I came in the next morning, his PAD was 12. And everybody thought everything was fine. Well, it's not fine. Granted, he's still making urine and his numbers are okay, but he's dry. You know, and he's a young kid, so he didn't bump his creatinine or his liver enzymes, and you know he had some reserve. But you take somebody that's 70, already has chronic kidney disease and has a vasculopath, you will seriously hurt those people. Those numbers you need to know, and I'll talk to anesthesia.
Yeah, say, let me know if they come up without them.
Well,
So I
they
Yeah, it
did
happened last
yesterday.
night.
Last night,
I tried to
the
talk
heart
to Kasha.
didn't have
They
them,
didn't know
we
them?
asked them,
Yeah,
they
she
didn't-
did-
she was
she
like,
didn't know.
they're in the paperwork.
So,
No, after surgery, you should see an improvement in your PAD and your CVP.
depends.
I mean, it not like right away, but because that patient's already used to those kind of filling pressures.
Mhm.
But once they have surgery, you should see over a long period of time that those should actually improve.
It depends. You talking about like in the hospital or
Like
is
for
like an
instance, this
outpatient?
guy in 10 had his aortic valve replaced.
Yeah, well, it should in theory, but
Uh-huh.
some people that like get pulmonary hypertension because of that kind of stuff, some of that stuff's not reversible.
So it's gonna stick
Yeah,
around.
so it's
And
highly
end up
dependent.
going on medication for
Yeah.
pulmonary hypertension.
Well, possibly.
Mhm.
It's highly dependent. Some people reverse and some people don't.
Mhm.
You know, because once your lung gets stiff and non-compliant, I think you're kind of screwed. But if you're still in that transition period where you catch it early enough where the damage isn't so bad, I think some of those people will reverse, but it's highly dependent,
Okay.
so.
So for that same guy in 10, so you said his starting starting PAD was 25?
Yeah, it was like 23,
like 20,
25,
like-
yeah, it was in the high,
In the mid-20s.
yeah.
So,
You talking about the guy that's in there right now?
no.
Yeah, yeah.
Oh, they got this in there right now?
Yeah.
Oh, okay.
Well,
okay.
see, when he came up, his film pressure was right what it was when you came in next morning. It wasn't no different from when he
Yeah.
came up the OR.
Yeah.
And we didn't have any paperwork then on him
And
either.
what was the
Tell
first
us
thing,
anything
what
different.
was the first thing I gave him?
I'll be in the-
So when they tell you it's in the paperwork, what are they
But
talking
I'm just saying.
about?
No.
Cause
They don't want
That's why
Liliana
there's no-
had him when he
I
came
know they
up.
don't wanna
She
put
got
it
him when he came
out,
up.
but-
Which is fine.
She didn't have that paper.
But they shouldn't, exactly.
She didn't have-
Well,
Contraception
that-
should
that
be-
needs
She
to be
said
passed
she
to-
told all the numbers to Bates, cause she called Bates to get the
Mhm.
blood products and stuff. And none of that changed. It was all the same from when he brought up
Well,
to the next morning. Now, I mean, if they were different pre-op, we didn't know it.
yeah, well, that's goes back to, you guys need to know those numbers. You see what I'm saying? Like,
Right. So for him, so he was we fixed it, we repaired his aortic valve, right?
Mhm.
So if his starting PAD was 20 whatever in the 20s, is that specifically where we want to keep him, or we want to keep him even better tanked than that?
that's
more
where,
tank.
that's where I would probably try to get them back to
Okay.
kind of correct stuff.
Okay.
I don't know if I would necessarily
Tank 'em
go
more.
over that,
Okay.
but I would try to keep them as close to that number as possible.
Okay. Because I feel like someone said sometime that we try to, especially with the aortic valves, we try to tank them even
Yeah,
more
because,
than they're
so,
doing.
they get what's called left ventricular, well, they get hypertrophy, so their left ventricle gets this thick,
Right.
and it gets non-compliant,
Right.
so it doesn't do this, it does this.
Right.
So, if it's doing this and they're dry, guess what happens?
Nothing.
You got no, you got,
Yeah, nothing
yeah,
wrong with it,
yeah.
you know?
Well, you might have a normal cardiac output, you see what I'm saying? But,
Would
They're
you
not-
though, if they're barely squeezing, would you
Yeah,
have a normal
yeah.
output?
Well, he had very high cardiac output.
yeah,
Oh.
you know, that's just
Output was
reflex.
like 9.5 all night
Yeah.
long.
So, I mean, you just.
Index
you
But
don't-
is it gonna make it more
3.5.
stiff? It's gonna make it more stiff, right?
Well, the pump run in the initial period for about 6 to 8 hours makes them a little stunned and stiff. So that's why we pump them hard in the fall. And then it takes several days to get it off. But I mean, if you run them dry, you'll kill the kidneys. You put them up, you know. And some people, you know,
Doesn't come back.
you'll kill their gut. Yeah, it's bad. Like, believe me, I've seen it. It's not good. But I want to ask. I just want to run some things. That problems I've encountered. So, there's been a lot of orders under Dr. Bates's name, put in the computer, that we didn't order. So, the 6-minute walk thing, I'm cool with you guys putting it in, but call me. So over the weekend, the 6-minute walk was put in on Saturday afternoon, 1 o'clock. I didn't find out about it until Sunday when I made rounds, and all the lady needed was some Lasix. So instead, she went home with oxygen, delayed her discharge. But if you guys think somebody needs a 6-minute walk, I'm okay with it. Just call me, because there's other things to do than just give them oxygen. You know, like literally, I listened to the lady. She had crackles. She just needs some diuretics. So now she went home with oxygen, and now it's a big logistical thing. She's chained to a tank. You see what I'm saying? Like, the morbidity of something like that is not good. And if you guys are gonna order labs, if the labs come back abnormal, you better call somebody. There's been several people that have drawn labs that I didn't know anything about, and they came back abnormal. And I didn't find out until the next morning. So,
Now, what are we talking about? Are we talking like the replacement protocol that, or are we
no, I don't care
talking
about, no, that's protocol stuff. I'm talking about people ordering CBCs, Chem 7s,
like in the
complete-
morning?
Like on their
No,
own, like if they
like
know
on their
something
own
versus
during the
on their
day.
own.
Like,
Like not as in like, you know, we know that there should be one for the morning and we put one in.
no,
Not that.
No,
Okay.
I'm talking about like drawn in the middle of the afternoon
Oh, okay.
that wasn't ordered, and I come back in the next morning and something's funky with it, and I'm like, who ordered this? And then I look in the computer, it's under Dr. Bates' name. Then I gotta call Dr. Bates and like, did they call you about this? No. So I'm cool with it. Just call. And if you can rationalize it, I'm cool with it. But if it comes back abnormal, I need to know, because legally, if something bad was to happen from that, and some of them have been, you know, not trivial labs, okay? Like somebody's amylase and lipase were like 4 times normal. And they're still
yeah, I
getting
was
fed,
last night.
which is a big fucking no-no. And nobody was notified, GI wasn't on the case, and that's a, you know, when it comes down to something bad happen, who's gonna get sued? Us, you know, because, well, it looks like we ordered it. Well, we didn't order it, and then somebody is gonna get in trouble for it. So the easiest thing to do is just call. Most of the time, if you tell me what you're concerned about, I will gladly oblige you. But doing stuff on your own and not calling me when the results are bad is just not good. Other things. No pressors and peripherals.
Oh, yeah, no, I know, that's,
So,
we know.
just so everybody knows, the only thing you can really put in the peripheral IV is Neo.
Mia?
Yeah.
Alright, so,
And even then, it's still, not if it's on for long.
yeah, but
Never,
it's
never.
not long term, but
Yeah.
people need to know that, okay? People that get extubated that have NG tubes in shouldn't be in bed at 30 degrees sipping on water and ice chips with an NG tube in. Should not ever happen. I talked to Joseph, was it yesterday or the day before? The guy in 10 is on amio. He was in complete heart block underlying. You guys should be checking that pacemaker, pausing it throughout the middle of the night. If you notice they're in heart block, any kind, stop the amio, call and stop the amio.
How often do y'all check your pacers on hearts? Is there like a protocol y'all just kind of spot check or?
Spot check. Yeah.
At least like every 4 though,
Yeah.
hours,
Yeah.
you'd say?
I'd say it.
So,
Okay.
another thing is, you guys tortured me with a guy that was in bed 6 all day and all night. Highly anxious guy. All you guys wanted was some Xanax or Ativan for this guy.
Oh, the lung?
Yeah, and next morning I came in, and I talked to the guy. I was like, do you normally get this anxious at home? He's like, no, but every time you guys give me the albuterol, my heart rate goes into 140s and I get highly anxious. And he told me that, he told the nurse that yesterday, and that nurse called me and wanted Xanax or Ativan, but not relaying that to me. So, he told you guys that this is what precipitates it. I need to know that, because then I'll stop it, you know, instead of just, you know, giving him a bunch of benzos that he probably doesn't really need. So communication is key. Sometimes there's good communication, sometimes there's bad communication. And there's gonna be some times when there's a lot of question marks and nobody knows what to do, but we'll work through that. But for the most part, communication medications.
Are the sheets getting done?
For the most part, so I know you guys don't like doing the sheets,
Hold on,
but
Tasha.
here's my reason for doing the sheets, okay? A lot of you guys are new, and when I talk to you guys in the morning, I get the sense that you guys really don't know how to present a patient. Like, you guys just tell me jibber jabbish, well, I gave him some volume, he's fine, like, so that's really not the way to present a patient. You know, you should be like, hey, this is Mr. So-and-so, he's had 3 doses of cabbage, expanded on time, you know, numbers are good, hemodynamic stable all night, blah, 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 no issues, or whatever the issues are in the systematic fashion. The other reason I put on the bottom of the sheet is because I want you to tell me what we would do for that patient. So that's a big thing. Those things never get filled out. The assessment and plan never get filled out. So that tells me if you fill that out, you're thinking about what that patient needs, which betters their care. So when you don't do it, it kind of tells me that you're not quite sure what they need, which is kind of goes to the patient care. So if you don't understand what they need, then we don't try to direct the therapy in that way. So those sheets need to be filled out. The bottom part I really want filled out because it tells me your train of thought. And that way I can better help you guys understand what needs to happen to that patient. So that's the reason for the sheets. It's not trying to get anybody in trouble, or it's just strictly for you guys to build a consistent practice of presenting patients and let me know that, yeah, you're on the night shift, but this is what needs to happen during the day shift for them to go home. And that will tell me that if that goal's not met, then you know there's a problem and we need to find some way to fix that problem. So that's the reason for it. So, all right. Any other issues? Anyone want to talk about it? All right.
Oh, you know what, there is, thoracotomies, when they go home, do you allow them to drive right away?
Thoracotomies, I usually let them drive in a week or 2 if they're off pain
Okay.
medicine,
Okay.
but it's highly variable.
Right.
Some people are in a ton of pain medicine, they don't drive. But what like I told it, most of the nurses just let me do all the talking, because I see people that are carotid 3 weeks after in clinic and they haven't drove because the nurse told them not to drive, which is not true, because I usually let carotids drive in about 3 to 5 days.
Well,
The only ones I truly address driving is the hearts.
Yeah.
well, but I told the
That's-
thoracotomies, if your airbags deploys,
Please have
you're not
a
gonna pass it.
please have a
Yeah,
Maybe you should let her walk.
Yeah, well, that's true. You know, it's highly dependent. You know, some people, we do a thoracotomy and they're not in any pain. You know, and
And then others.
And others
and
are
others,
dying.
yeah, you know, so it's highly dependent, but
Okay.
that should come from me and Dr. Bates.
Well, and then we can reiterate, if you're on pain medicine, you can drive.
No.
So that will be done, cause that is where we're giving you report, so whoever went down to the OR should have gotten that information.
Me and Nana,
No,
No.
not.
No, you guys got the
11.
carotid.
We got the carotid.
we got the.
You guys got the carotid.
Who picked up the heart? Nobody? Anybody?
I'm trying to remember who picked the heart
Where'd you
up.
get it from?
I got support at the bedside. I didn't go to the OR.
Okay, so first of all, that is a process that needs to be changed.
Randy went down to get it until
So where's the
the
anesthesia?
medicine
Where's the
was
anesthesia?
ready to change his shift.
No, you will not get that. We have discussed that time and time
He
again.
knows. He was
Where's the
telling me.
anesthesia record?
It's in the chart,
Probably in the
probably.
chart. I don't have the chart in my hand.
Okay.
That's
So
why I
Randy
found
didn't
it.
give you numbers then, when you brought the heart up?
I know.
I didn't need numbers from him.
The thing is
We were
like-
settling the patient. The patient
Okay,
was
so they're
rolling
giving
through
them
the
in the
room.
OR, is that okay?